Great, thank you very much. So hi everyone, my name's Sophie. I'm a trainee cardiac scientist based in Oxford, and I'm going to present my MSc project today, which is the use of CPET to separate the grey zone between early dilated cardiomyopathy and left ventricular dilatation in highly trained athletes, which I appreciate is a bit of a mouthful, but hopefully as we go through, I'll sort of unpick what it's all about. So the grey zone, it's the apparent overlap, morphological overlap between an athletic heart and early dilated cardiomyopathy. The athletic heart, which comes about as a result of high load, particularly endurance training, where we see an enlargement of the left ventricle, and this remodeling of the left ventricle is beneficial in able to have a higher aerobic endurance performance. But at rest, the left ventricle appears abnormal, and that is significantly enlarged compared to reference values. Similarly, early DCM or early dilated cardiomyopathy, which typically comes about as a genetic mutation, also sees an enlargement of the left ventricle. And as the disease progresses further, we see a thinning of the left ventricular wall, causing LV dysfunction, the actual pumping function and relaxation properties of the heart becoming poorer. And also it lends these patients to significantly higher risk of arrhythmias and sudden cardiac death. The catch being, though, at rest, both of these conditions look pretty much exactly the same. And so it's very hard to just tease these two conditions apart, given they both have enlarged left ventricles and also have low to normal outputs when at rest. So what's the problem with that? So particularly for us in Oxford, we are a military affiliated hospital, and we get a lot of referrals from the military who are query grey zone. As you might appreciate, military personnel are quite highly trained athletes, but they could also quite easily have early DCM. Within healthcare, typically these conditions are only tested at rest, and as I've already said, they look exactly the same. So we tend to get inconclusive results, run risk of patients not receiving the correct care or having delayed care, high risk of sudden cardiac death going undetected. And specific to the military, there's the inappropriate discharge from the being discharged from the military, which is obviously quite a significant impact upon these patients' livelihoods. So what do we know already? Only really in the last few years or so has this sort of been started to be investigated. But we do know that these two conditions can be teased apart when the patients are put under exercise stress, where we start to see that the athletic population start to show improvements in their ventilatory efficiency, stroke volume, which is the amount of blood that is expelled from the heart with each contraction. We also see higher VO2 peaks, so VO2 being the amount of oxygen uptake during exercise. And also that's at peak exercise and also at the anaerobic threshold. The anaerobic threshold being the point at which during exercise we start to respire anaerobically, get the buildup of lactic acid. I'm sure you can all relate to that sort of feeling. But it's a very functional, important level of activity, as it's sort of the level of exercise capacity required for day-to-day activity, not necessarily the peak exercise, which is more towards elite athletes. And overall, dilated DCM patients demonstrate a weaker CPET performance. And just for those who perhaps don't know what CPET is a cardiopulmonary exercise test, which is what we use clinically to put patients under stress. It's a functional test of overall capacity, looking at the synthesis of respiratory, cardiac systems working together. It's non-invasive. Ideally, we get patients to go to their maximal effort, and we look at ECG, we look at respired gases, perceived exertion. Sometimes we do blood gases as well. So my project was to look at CPET and also exercise echo variables that can best discriminate between these two groups of an athletic heart and early DCM. So how did I do it? This is perhaps a little bit overwhelming, but here we are. It's a retrospective study. I managed to recruit 19 referrals who were given to us consecutively from the military, all for query grey zone. They were all male, and using a pragmatic clinical consensus of 3 consultant cardiologists, they looked at a holistic view of their entire clinical history, along with variables listed up here, which are sort of based on the national guidelines of what's considered normal, what's considered athletic, to be able to separate those participants into groups of, so we had 12 in the AA or athletically adapted group, 4 considered to have early DCM, and then 3 were considered not to fit into either bracket, so were considered normal for the time being and were discarded from the rest of the study. So what did we find? Exercise echo. So first of all, the stark difference here was the difference between diastolic function being the ability for the heart to relax. And so the grey bars, and the black dots represent our athletic population. So both at rest and at stress, the athletic population showed a higher in numerical value of diastolic function. That's not to say that their diastolic function was better. It was actually compared to reference guidelines, it's actually supranormal. They showed above normal diastolic function compared to the DCM group, showing lower values. And they also showed faster velocities moving through the heart, both at rest and stress, suggesting that the athletic population were able to produce higher forces due to increased perhaps cardiac mass, both at rest and stress. For CPET, across the board, we saw that the athletic population in the grey bars were able to produce a higher workload. So that's the watts, the exercise intensity, both at the anaerobic threshold and at peak exercise compared to DCM. And also they produced a higher O2 pulse, which is a surrogate marker for stroke volume from CPET. As I mentioned before, stroke volume being the amount of blood that we expel from our hearts with each contraction. And importantly, given the most prominent paper in this area from 2020, this was one of the CPET variables that wasn't quoted at all. And it was interesting that in my very, very small population, this was quite a significant finding. We also looked retrospectively again, a number of the participants had cardiac MRIs, which is the gold standard for sort of measuring cardiac volumes. Apologies for all the acronyms here, but essentially the athletic population across the board for both volumes when the heart is contracting and when relaxing, they were larger compared to the DCM groups. The LVEF, or left ventricular ejection fraction, was also higher in the athletic population, not significantly, but this was something, as I say, mentioned the landmark paper a few years ago, referenced as being a very strong predictor of DCM. Didn't find that in my population, but it was higher in the athletic group. And finally, we saw that the exercise economy, which is the amount of oxygen used per workload, per watt, if you like, was higher in DCM, both at the anaerobic threshold and peak exercise, suggesting that the DCM group were having to work harder to compensate for perhaps their cardiac limitations compared to the athletic group. So what does this really mean overall? It means, yes, found that CPET and exercise echo are useful tools in distinguishing the grey zone, particularly considering O2 pulse, workload, and diastolic function. We saw that the athletic group had a supranormal diastolic function, which is most likely secondary to diastolic suction forces. They're able to produce such great forces within their left ventricle that the blood is not just pushed out, it's also sucked through. It's a good adaptation to be able to have better aerobic endurance performance. The DCM, a lot of them showed to have fibrosis or scar tissue when going through cardiac MRI, and as a result, we saw these with having their reduced LV filling and geometry, which, as I mentioned, resulted in a lower stroke volume or O2 pulse. The ejection fraction, as I mentioned, was not a strong predictor of DCM in our cohort, although there was a difference between groups, but not a significant finding. But perhaps more relevantly for a clinical population, we saw that the athletic group, or those who were considered the athletic group, I should say, showed improved functional capacity and improved exercise economy, which was particularly relevant considering a clinical population where peak exercise, as I said, isn't as relevant. It's more about the day-to-day exercise ability. Limitations, lots of limitations here, particularly my population. Only 19 of them, all Caucasian males from the military, so only looking at a very small slice of society. There was lots of missing clinical data. As I mentioned, it was a retrospective study, so I couldn't introduce additional tests to these patients' pathways, couldn't influence that, so I had to just go with what they'd had done. And also there was an inherent bias, particularly with the pragmatic consultant grouping. Despite them using the national guidelines and looking at the clinical history, there was a bias behind it. But overall, key outcomes, yes, identified CPET and echo variables to distinguish the grey zone. That was our O2 pulse, workload, and diastolic function. And these perhaps could be markers to be used as we go forward to inform these sorts of referrals. We're looking to identify difference in oxygen mechanics. Yep, we saw that there was a reduction in O2 pulse in our DCM group and a reduced functional capacity. Looking much further ahead, these results could perhaps inform and accelerate diagnosis and the appropriate treatment for these two groups, now being able to separate them a little bit more clearly. Specific to the military, reduce the risk of being unfairly discharged, and more importantly, being able to treat and preemptively treat the risk of sudden cardiac death in these DCM patients, and overall creating a more patient-focused and efficient journey for these patients, rather than having to come in for multiple tests done at rest, test them at stress, just distinguish the groups, and go forward from there. And that's it. Thank you very much.
Thank you, Sophie. Any questions for Sophie?
Hi, thanks for the interesting talk. So you said you had kind of 3 normal patients that you excluded from your grouping. Did you think about kind of going back to those patients once you kind of looked at the different metrics and see kind of where they lay on that scale?
Good question. The honest answer is no. I haven't been back and looked at their numbers, but they were considered so borderline in the groupings that they didn't fall nicely into each group. And looking at their clinical history as well, which doesn't have a number behind it, it didn't seem appropriate, or there wasn't really a need to go back and look at them. But talking with my project supervisor, our plan going forward, if ethics approval sort of allows, we're hoping to sort of monitor this group of 19 patients going forward and see how time influences these patients, because as best as we can do in trying to diagnose early DCM, the ultimate best test for deciding if someone has a DCM is to wait for it to present in a proper clinical way where they've got like actual diagnostic parameters are met. So they'll still be included in those 19 going forward, and we see how time influences them. But no, haven't gone back and actually see where they fit on the scale yet.
Any other questions? One over here, and then another. Get you moving around for.
So obviously those sort of DCM-like changes you see are adaptive to the increased stress. Is there a point where that becomes then maladaptive, for example, in old age, when you've got dilated left ventricle? Is that then a problem?
Exactly right. So crucially for this cohort, they were early or considered early DCM. So although they were considered early DCM, they are still patients who are able to perform to a very high level of athletic ability because they're still in the military. As DCM progresses and it becomes the full-blown cardiomyopathy, these patients are very unwell. They're very functionally limited. They have high risk of arrhythmias, heart failure. DCM is one of the leading causes of heart failure. So yes, as the disease progresses to be much more morphologically apparent, they become more and more restricted in their day-to-day.
Is that the case with the athletes as well?
No. So hence, it's only a problem, the grey zone, at rest at the very early stages of DCM. As I said, time is the best discriminator for these two groups, because as they fall into their categories, they become further and further apart, but it's at that very start that they look exactly the same. But with any treatment really in NHS, healthcare in general, if we can treat earlier, diagnose earlier, it's better outcomes for the patient.
I've got time for one more question.
Hi there. I was just curious to ask whether there was a similar relationship that you found in your experience at the hospital or through your research with HCM, in addition to your DCM research.
Good question. So I have to be completely honest, I haven't looked at HCM. But my understanding of HCM is, HCM is a hypertrophic cardiomyopathy. For those of you not in cardiac, is when we see the thickening of the LV walls, unlike DCM, where we see the thinning and the expansion of the LV. HCM, again, do become very limited and is also one of the causes of heart failure, and become very functionally limited in their day-to-day activity, the exercise capacity. There is a grey zone of this overlapping between a athletic heart, but I think that's more to do with strength-trained athletes, so endurance-trained athletes tend to see enlargement of the LV to allow for larger cardiac output to, be able to have a better endurance performance. Strength-trained athletes tend to see a thickening of the LV mass to be able to deal with higher pressures and blood volumes that put on the stresses that are put on the body during strength training, and they will more typically overlap as a grey zone with HCM. So there's sort of the dilated group, which is the endurance and the DCM, and the strength trained group and the HCM. So it's the same, but different.
Okay, thank
Thank
you,
you.
Sophie. I'm